guys show up. Again, very, very poor outcomes then on those kids where only 1-2% are neurovascularly intact after ROSC, if they survive at all. And then bystander hesitation. Even when dispatch is telling them, they flip to their pediatric CPR card and walk them through these steps. They're still hesitant, even when they're getting step by step. This is what you need to do. And they're still a little hesitant to do that. So, Journal of Emergency Medicine, AHA guidelines kind of target, and this is kind of their new, and it's been this way for a little bit, but 1 minute of recognition for arrest, cardiopulmonary arrest in kiddos, and then 2 minutes on hands on chest. That should be kind of max for the best neurovascularly intact kid after ROSC, after cardiopulmonary arrest. That should be the goal. And that's hard because that's mostly bystanders. Unless you guys are just in the right place at the right time, or we are, then that's going to be a bystander. That's going to be like, oh crap, I'm freaking out. That what am I going to do with this little one? I don't even know if they're sick. I don't even know if they are breathing or not, or if they have a pulse or not. So that's pretty high goals for that. And then kind of the third step of this, increasing the outcomes of these kids, is this idea of having this deliberate pre-arrival discussion, and that's for you guys. So you have this radio chatter, and for us too in the ED. So we hear these call, or we might get a pre-call before you guys call in a report, of actually having, what are we doing? What are the roles? Let's set everything up. Having this kind of deliberate talk about what's happening, the age of the kid, why are they down, going kind of through your differentials, your reversible causes, all that stuff, just all those things that you could be talking about beforehand, which kind of goes back to that saying, luck favors the prepared. And the more prepared you are for any kind of call or any situation, the luckier you're going to be. Just thinking, if you hear, and if you guys haven't looked at this, use this guy for pediatric stuff, this sign, I don't know how much it costs, but he's got a lot of free stuff online too, but it's really good for pediatric resuscitation and pediatric standards overall. But so just think, if you get a call for a one-year-old that's down or in cardiopulmonary arrest, CPR is being conducted at scene, immediately you can use these predicting cards and already have all the dosing, ET tube size, iGel, keying size, whatever you're going to use, their bolus size, just based off these predictors. And all of this, equipment size, what's the dose of epi, what if they're in VTAC, VFib, what's the joules we're going to use. All that can be found fairly simple, and that kind of goes back to this deliberate discussion of, I know it's a 5-year-old, let's get ready for a 5-year-old. So there's also a new kind of push, which came out 2 maybe years ago now, a little bit longer maybe, but we're staying more in the scene when you arrive on these calls. So I know in the past it's been kind of scoop and run and go and get them to the ED, because that might increase chances and it's faster, and there's more help there. Actually, I kind of came up with this, if you stay on scene longer, it actually improves outcomes in these kids, and they kind of came up with this, stay in the scene, stay on scene, and then stay in your lane idea when you get these calls for these kiddos, because we don't do it a lot. So we kind of get focused in on the kid and we kind of lose sight. So kind of stay in the scene is not losing sight of everything else. So when you walk into another house, you kind of need to be aware of your surroundings and safety and that type of thing. We don't do that a lot when the kid comes in. I'm so focused on the kid and what's going on, and adrenaline's pumping, and this gets lost. So is the kid down because dad just beat him and dad's still in the back room with the gun now, and you're not focused on any of that? And so kind of staying in the scene and being aware of what's around you. And then staying on scene. So staying on scene, starting good, just BLS first, and then PALS, establishing airway, establishing IO access, and then stay in your lane. This kind of goes back to the idea of having these deliberate talks, these deliberate discussions about here's our roles, especially whoever's a senior on the truck or at the scene, saying, here's the roles. You're going to do A, B, and C. I'm going to do X, Y, and Z. Those are our roles. And doing those and staying kind of in that helps a lot. One thing that we kind of forget, especially in the ED, is you guys have a completely added layer of stress and complication to these calls that we don't have. We're kind of isolated and protected back in the resuscitation bay or trauma bay back in 40 and 41, where it's just us. Family's away. There's no onlookers. There's no passerbyers. You guys have to deal with all that, and that just adds tons of stress and family and all that. Now you have maybe dad, mom, grandma, someone doing CPR. That is very traumatic, obviously, on them, and plus all the family and whoever else might be there. We don't have that, so it's just an added stress that you guys have to deal with that needs to be kind of thought about at least before. That's kind of staying in the scene and kind of knowing how to deal with that stuff, those deliberate talks, which I'm glad that we don't have to deal with a lot, and you guys unfortunately have to. So we talk about 1% to 2% neurovascularly intact kids. Why have those numbers not changed a lot? So they kind of came up with those 3 pillars. How do you change that? So there's a big study that came out in 2018 that looked at a EMS fire department up in Chicago, a really large service area and department. They had significantly higher improved survival rates, and these are neurovascularly intact kids. That's kind of the outcome measure. 35. So theirs was 35% of their kids that when they went on these calls were neurovascularly intact. That's huge. The national average is 1% to 2%, and they're at 35%. So the question was kind of asked, well, what in the heck are they doing to have their numbers so high in the same situations where it's a witness of arrest or at least a respiratory arrest, and they have such great numbers? What are they doing? And so they kind of dove into their methods of what they're doing, and it kind of came out to some key factors that they have. One was with their dispatch. More education with dispatch about implementing, enhancing dispatch, implementing CPR, and getting better cards, getting better ways to initiate quicker CPR for the bystanders. Of course, that's number one. Bystander CPR, hands on chest, number one for improving outcomes of these kiddos. And they also did these simulation trainings almost once a week. They'd have kind of spontaneous pediatric simulation training just when they're just sitting around. The senior on that day would, for that whatever week, would say, throw a baby in the lap of one of the medics or one of the EMTs and say, go, it's a floppy baby. And that would happen about once a week. And then you go through the whole process. Why? Because we don't do a lot of these. We don't do it. So when we hear that, we kind of get a little pucker factor and we freak out a little bit. And again, it's not that 75-year-old from Joplin Gardens. It's very not a normal call for us or a situation. So they train that a lot just in simulation. And then they had this pre-arrival plan, which kind of goes to this deliberate discussion about what we're doing, who's doing what, and getting stuff ready before they even arrive. And then staying on scene. So they kind of were following this idea of let's not scoop and go, let's stay on scene. Let's just stop for a minute. Let's secure an airway. Let's secure lines. Let's make sure we're doing good quality PALs before we even think about getting in the truck and going to the ED. Because without that, we know that's the most important. So without that, what's the point of rushing off? Again, if you do that, you're kind of just delaying hands on chest, delaying appropriate PALs for these patients. And so just thinking about quickly, and we kind of go through some algorithms later. I won't bore you too much with the PALs because I know you guys do that anyway, but algorithms are, I don't know, boring anyway. So, but this is kind of what they did in that study when they would stay on scene, is establishing an airway. So the number one cause for cardiopulmonary arrest in a kid is going to be respiratory. So airway management, oxygen is going to be number one for these kiddos for sure. If you think about reversible causes, and we kind of talk about this, for cardiopulmonary arrest. In kids, it's going to be, the H's and T's. I don't know if you've heard much about H's and T's, but reversible causes, you always have to be thinking about those in these kids. Hypoxia is going to be really high on the list, number one. Hypoglycemia is going to be pretty high on the list. So establishing that airway, making sure we're having good compressions, good airway delivery, they're ventilating good. So monitors in place. It's very, very rare to have a kiddo go into VTAC, VFib, unless it's some type of very strange situation. It's very rare. So most of the time on our algorithm, and I'll show you in a minute, there's like a pathway for VTAC, VFib. You're going to be shocking them. Very, very, very rare. Most of the time it's going to be on this side. They're PEA or asystole, but mostly PEA. Why? Because they're in respiratory. They're in hypoxic failure. So they're going to be reversible causes. But just to know about when do you need to do rhythm checks? When are you going to be delivering shocks and how much, just in case? There's been a big push about don't even waste time of trying to establish an IV in these kiddos. Go straight to the IO. Why waste time? You can deliver the same medications. So why waste time doing that? Get the meds in, because all you're doing is delaying their epinephrine at that point. And so that's been shown repeatedly. The more delay in epinephrine for these kiddos, the worse outcomes they have. Less chance you have for ROSC and less chance or lower chance of neurovascularly intact after you get ROSC back. And then just having an established algorithm that you guys work through. I know Metz has one, and Dr. Brown kind of walked me through some of the protocols, or SOPs, or just standing orders for algorithms, but having this algorithm that you're running through. If you don't do that a lot, it's not just on the top of your head, and that's why simulation also is key and helpful, especially, well, at least was shown in the research, doing tons of simulation, because then that algorithm is fresh in your head and what you're doing. All right, let's talk a little bit about ACLS. I feel like it doesn't really matter because you're freaking out anyway, and you're going to be doing the typical stuff anyway, but ACLS and PALS is all about algorithms. So think about, and I just put this out to the crowd, I won't pick on anybody in particular, but say you show up to the scene and you're handed an unresponsive floppy baby. They're breathing, maybe agonal, but breathing, and they have a heartbeat. What's the first thing you want to think about? Okay, good. Is there something else? Anything comes to mind? Think about your H's for reversible causes. What's something you check on almost every patient, regardless of age? Temp and sugar, yeah, glucose, right? So that's usually number two, hypoxia and glucose. We had one not too long ago, well, it's probably been 6 months ago now, that from Outline facility came in, and kind of this floppy baby. They were breathing, they were kind of agonal, and their glucose was like 18 or something, 16 maybe. They didn't check just because you don't get those a lot, so you kind of get focused and oh crap moments. But hypoxia, hypoglycemia, low sugars are going to be kind of your two, and then shock after that. So yeah, anybody know the dosing off the top of their head of kids, just in general, for glucose? Those where you pull out your card and be like, oh crap, okay, it's 5, okay, I'm going to give this much. So there's a pretty quick rule you can use, which is kind of nice, without even knowing, having to pull out a card and look and figure it out. It's the rule of 50. And that's what we use a lot, even in the ED. We don't even look. We'll just rule of 50. So nurse will come in and be like, hey, the kid, we'll say infant, say 1 month old, or so glucose is 30. We don't really look up dose and say we're going to give this. We just kind of use this rule of 10. So we're going to use D10, 5 cc's, 5 mils per kg of D10. 5 times 10 is 50. In the kids, it's D25, and you're going to have 2 mils of that. So 25 times 2 is 50. Teenagers, adults, kind of what we do is like 1 amp. So it's one 1 cc per kg D50, 1 times 550. So it's rule of 50, and that's kind of just easy, kind of easy to remember, and plus just kind of a gross approach. That's going to get them up enough as they're going to respond to that, so you don't have to necessarily stress about trying to find exact dose. And oh my gosh, they're 6.5, and almost 7. What do I ask? Just the rule of 50, we use that quite a bit. It's pretty handy to have. All right, let's see. So these so much we won't use. I just want to kind of put these on for completeness. A lot of times Broslo tapes and these prediction cards will underestimate weight a little bit, or overestimate, just depending on which one you're using. So there's a lot of different formulas to estimate a weight based off age. So, and this is kind of what we study in our tentallies and what we're kind of expected to know, these different formulas of, hey, you're given a age of a child, now what's their weight, now base their epinephrine drip or whatever it might be off of that. So they have all these different ones. So you think about, well, what's the best one to use? And so research shows that this best guess, ironically, because it is kind of a best guess, is the best one to use. Again, I feel like math, if you're going into medicine at any level, like taking math in high school, college, and on, shouldn't be the algebras and the calculus. It should just be like being able to do simple math with people yelling at you with like a floppy dying baby in your hands, because it's like, oh crap, 5 + 1 × 2, hold on. So again, that's where the prediction cards and Broslo tapes come in, because you don't have to worry about that. But so if you think about, just like you have, I don't know, say if you have like a 5-year-old, let's say a 4-year-old, so 4-year-old, let's do 3-year-old. So he would be 3 + 5, 5, 6, 7, 8 times 2 is 16. So that best guess is saying he's about 16 kilograms. And so if I run back to kind of those prediction cards, 3-year-old, they're saying it's 15 kilograms. So pretty close. Again, this prediction card underestimates the kid's weight a little bit. So then all your dosing is going to be a little bit lower than what needs to be, or a little underestimated. So best guess is kind of, if you're going to use any formula, have one in your pocket to pull out, that's the one that you would want to have. So those prediction cards, we have these formulas that we can memorize for weights, because then we can do weight-based. Does anybody use Pedistat or have that on their phone? So we use this tons, and if you don't, I don't even know if I think it's fairly cheap, honestly, if it costs anything. I think it was $5, right? Is it? Yeah, $4.90. Yeah, it's like $5, and it's amazing. So you literally, when you pull it up, it's just an app on your phone. When you pull it up, it literally comes up this. And so if you know the patient's age, so that you get a dispatch call and they're like, oh, 1-year-old arrest. Boom, I can hit age. And when you hit age, you'll say, what age? 1, save. And then now everything that pops up on this side, this will be your next screen, will be set for a 1-year-old. So then I can go airway interventions. And then if I click that, because that kind of falls under pulmonary arrest, it gives me everything I might need for that. Drug dosing, ET tube size, everything I could possibly need. And so it kind of goes through everything. So if you have a burn patient, that's 1. What do you need to do? And what are the dosings? And everything, cardiac resuscitation, etc. So for $5, it's by far the, or benzos I need to give them, and what dose and timing, and what my next step in my algorithm, when do I need to move to Keppra, and etc. So amazing if you have an extra $5, it's amazing just to have on your phone for the moments that we're freaking out and need it. But most of us find it easier than Broslo tape, because we just don't use those a lot too. So when you throw it down, and then you got to flip sides back and forth, and you got to kind of read, what am I looking for, and then you got to go to the right cart and pull, and you're like, oh my gosh, I don't know. This is so much easier for most of us. Some of our other senior attendings still love Broslo tape and disagree, but So if you don't, can check it out. If you have a friend or know someone that has it, you can always check it out. I have it on my phone if you guys want to see it too. Fairly amazing. And then the Broslow tape. So some issues with the Broslow tape too, kind of what we talked about before. So older kids, so 10, 11, 12, older. I have a 6-year-old that's like stupid high. I mean, he's not that high. He's big. He's like 98% height and weight. So he's going to quickly kind of get off this chart. So 43% of these kids that are 10 and above are off or longer than this. So then what do you do? So now you're like, oh, crap. They're 2 inches longer than this tape. Now what am I going to do on this 10-year-old that's a giant? That's where kind of these other prediction cards of the Pediatric helped a lot. Comes in. And also, if you do, so best guess formulas for weights, if you go back and look through each, red and blue and green, what level they fall in, they underestimate weight quite a bit. If you underestimate weight, then you're underestimating all your dosing for that weight. So it's kind of been a problem, and it's been researched quite a bit through why is it always underestimated, because it hasn't changed much over decades. So it's not necessarily updating with the sizes of our population. As our obesity rates rise, that's kind of stayed the same, and our obesity in kids have increased. So we're kind of underdosing kids using the Broslow tape. That's one of the issues with Broslow tape, or short sides of it. All right, so let's talk about a little bit of cardiopulmonary arrest. So we got to think about just anatomy first, right? Their anatomy is a little bit different than adults. We intubate adults quite a bit, but we just have to think about so kids are a little bit difficult for intubation just because of their airway and their location. So trachea is a little bit higher. It's more anterior, which always makes it a little more difficult intubation. They also have these big floppy tongues that they kind of grow into, but it's in the way. And it's in the way when you're trying to intubate. And then they have a much larger epiglottis to kind of get up and lift up out of the way to see. And all those kind of make that airway a little bit difficult for kiddos. Even though they're a little more pliable in their neck and easier to move around, those things make it a little bit more difficult. And then here's some of this. Again, you're going to mostly use your prediction cards or Broslow or whatever you guys use. But here's just a good estimate on what you guys mostly use uncuffed for your kiddos, right? Uncuffed. There's times that you'd use cuff. I don't know if you guys would ever use those in the field, but we'll kind of talk about that. But so uncuffed. So you think about 4 plus the age of the kid divided by 4 would be about 99% accurate for picking what ET tube size you would want for that kiddo. So if you kind of know that formula plus the weight formula, you're way advanced on the information that you need for drugs and how you're going to intubate if need to be, and et cetera. So 4 plus age. If you're going to use a cuff, I don't know if you guys use those or not, but it's 3.5, so not much different. So we'll use that one quite a bit. Just knowing, if I know an age, I can easily know what tube size I'm going to grab. And then kind of talking about like when the cuff would be better. When anything requiring higher ventilation rates or pressures anyway. So if you have a higher tidal volume or pressure for your ventilator settings, that's when cuffed is going to be better. I don't know if that affects you much around the field necessarily, but if you know this kid has severe asthma and you have to intubate them, of course, intubating an asthmatic kid is kind of the last thing you'd want to do. It's kind of very, very last step in your algorithm of trying to save this kid's airway, just because it's hard to get them off when they get on event being in status. But anything requiring any type of lung diseases requiring higher pressures would be a good reason to use a cuff. Otherwise, uncuffed is just fine. The rates of complications are about the same for both. It's just when is appropriate to use one or the other. So the rapid sequence intubation drugs for kids, like kind of the same for adults, honestly. I said it's a handout, but I should have said just kind of see your own, whatever SOP or standing orders that you guys have. We're talking about cardiopulmonary arrest. When you arrive, these kids are going to be in arrest. You probably won't need to do a rapid sequence. You could just be intubating and or providing oxygen initially and going from there. But I didn't want to bog you down with a bunch of dosing when you can just would look that up on either Broslo or to know if needed to do that. So talk about vascular access. Again, there's kind of a push now to don't even waste time for an IV access. Go straight to an IO. Most common place is a proximal tibia, about 1 to 3 centimeters below anterior tibia tuberosity. So you'd be medial to that, right in this region of that kiddo. Right, it's kind of that flat area that you feel. And then you're inserting. So when you pull back and try to get marrow, if you don't, remember that's not necessarily a bad location. You can still try to flush that. If flush is okay, that's still okay. You're not necessarily going to get marrow every time. And knowing that I know I'm in and it's okay. If you don't get it, that's still fine. You can still try to flush. If it still flushes fine, then it's okay to use. Here's just kind of pictures of it, kind of where you're going through the cortex of the bone and where you'll be. Sorry, I feel like I have my back to you guys all the time. So again, just kind of the cortex of the bone, where you'll be at. So this little red one is most of the time what we'll be using for those, because the other ones are way too long. You'll go through. Unless the patient's huge, but these little guys are what the ones we'll be using quite a bit. And the same kind of drugs can be pushed through, your IO than your IV access. On the flip side, what we worry about is drawing blood out of that. Some of the blood values are different, but you wouldn't necessarily have to worry about that side of it. Let's see. Like I said before, just kind of simple algorithm of running through CPR in these kiddos. Very rarely are you ever going down this path. If you show up and they're via or VFib or VTAC, that's pretty rare in kids. Why that's rare is because it's usually hypoxia is going to be number one, hypoglycemia, shock, some of these reversible causes, hypovolemia. This is rare. So you usually jump into this side pretty quick and running through your algorithms, establishing airway, establishing not delaying epinephrine, establishing IOs or some type of line, and then considering advanced airway if needed. And then just repeating that. So the shocking is a little different. So if you're going to shock these kiddos, which again is on all these prediction cards, but if you're going to shock these little kiddos, you're thinking the first shock is 2 joules per kg, and the second is 4. And then you can repeat that, obviously. And then you're just repeating your dosing of your epinephrine, just depending on dose and rate and weight of the kid. I don't want to harp too much on these. I think this is pulled from your guys' kind of SOPs or standing orders, at least from what I got from Dr. Brown and them. So again, this pathway for kiddos is going to be more or less pretty rare, VTAC, VFib. You'll be over in this pulse PEA, which is pretty straightforward. You're going to be running through your epinephrine after a line's established every 3 to 5 minutes. CPR continuous until you arrive into the ED. If you have to shock, you have to shock. The only difference is on your guys' protocol, a lidocaine is used on this side for VTAC, VFib. Again, that's pretty rare, but and then just talk about APGAR score just a little bit, which I've always hated, but I wanted to, just for completeness, throw it in because I want to talk a little bit about neonate resuscitation, which is slightly different than, 4, 5, 6-year-old. 5, 6 day old is going to be slightly different for you. There's all these measures for APGAR. They always want it, and I always have to stop and think and go back and have to like, okay, it's 1, 2, I don't know. So, but just for completeness, I want to kind of put this up there. The best score is 10, 2 points for the 5, or in the worst case, 0. I always think when I hear APGAR, I always think of more of this. I think, okay, this is an 8 or a 10, and this is a 0 or a 1. Like 8 or 10, 0, 1, and any baby in between is like a 5. That's kind of how I think about it, just to make it simple. Now, if I was going to have to call consultation for OB, then I would do that different, and actually come up with a score. But all right, so this is more neonate stuff. So neonate resuscitation. Remember, neonate resuscitation is even more important for oxygen hypoxia than even the younger kids. So you're really going to be focusing more on getting them oxygen early and getting respiration to them earlier beyond anything else. And so we'll kind of break this down a little bit more. I don't want to get into too much detail just because algorithms are exceedingly boring to walk through, but just for completeness and review sake, you kind of start your algorithm here, and this is neonate. So they just were born, or you just delivered one on the truck, or they just they're 2 days old, or might be. And so you're kind of thinking, is it term? Are they, and they just delivered at 27 weeks, which even is more pucker factor. And what are you going to do? Versus, are they term? Are they breathing, crying? Do they have a good APGAR, 8s, 10s? It's fine. And then it's just supportive. You're going to give them to mom. You're going to think about temperature and keep the baby warm. Check a glucose. Those are kind of the 2 important things. Keep the baby warm and give them sugar if needed. Are they kind of 2 things? And then just emotional support with mom and the baby. The problem is if they're not, so if they kind of drop down in this airway, so they don't have good tone, they're not breathing, they have an APGAR 4 or 5, and it's been 10 minutes, and you're like, then you're kind of moving down your algorithm to see their heart rate. So in this case, respiratory and heart rate kind of go hand in hand. So as they're improving with the respiratory rate, you want to see their heart rate improve. That's why heart rate's kind of listed here. More than their respiratory rate. So if you think I'm providing good respiratory rate to this patient, but their heart rate's still low at 100, less than 100, that's problematic. That means they're not ventilating good for whatever reason it might be. They're still gasping or apneic. Now, if they're still okay, then this goes up to this. Is their heart rate less than 100? No, it's 120. Great. Let's get them up here and let's watch them and make sure they do okay as we move on. So this kind of picks up where that leaves off there. So say they're not. Their heart rate is less than 100. Yes. Okay. Now I'm going to provide some positive pressure ventilation. I'm going to bag them for a little bit because again, it's all respiratory driven at this age. They're young. It's 9 times out of 10 it's going to be respiratory unless they have this rare heart malformation or problem. So now you're providing oxygen. You're bagging them a little bit. As you do that, you want to see the heart rate come up. You got good ventilation, you're bagging them good, and they're getting now good SpO2 kind of circulating through. If that happens, great. Now you can run back up and make sure everything's okay, and then go back to mom if everything's responding fine, especially if you can put them blow by or whatever might be on oxygen. If you're providing that and their heart rate's still below 100, that's problematic. Now you're either not ventilating good, or the patient's not ventilating good, or something else is going on where they're not responding, and goodness, by heart rate. You think about SpO2 monitoring in these kiddos too, these really young ones. You want to think about pre-ductal versus post-ductal coming off the heart. So they still have openings in their heart that causes blood flow to go right to left shunt or left to right shunting. So you guys have to think about, you want to be measuring that O2 oxygen in the right hand. So that's all pre-ductal. So that means how much oxygen is getting to their brain. So kind of right arm, right hand, right neck and brain. Our neck and brain is all pre-ductal, and that's kind of where you want to be measuring. If you're measuring on the left side, that's going to be lower oxygen, just because it's now shunting to the whole body too. So always want to be measuring that in the right hand, or right ear, or up in the ears if need be. Bilateral doesn't really matter. And then obviously reassessing as you're working through your algorithm. So now we're here. We've kind of given oxygen. We've worked on our ventilation. They're doing better. Their heart rate's improved. It's 120s, 130s. It's going up. Great. Now we can give the mom. We can now do like post-resuscitated care, watch them a little better, get them monitors, etc., lines, whatever it might be. If they're still not, and they're kind of running in the 80s, you're bagging them. Is there a problem with ventilation? That's the first step. Am I ventilating correctly? Is it a problem on my side or the patient's side? And so and we'll talk about in the next slide or two, but how can I correct problems on my side of ventilation? I'm trying to deliver this air through the bag and it's just not working and it's my fault, versus it's something wrong with the patient and they're just obstructed or have other issues going on. And we'll talk about how to correct some of those. Oh, sorry. And then you think about if their heart rate's less than 60, that's when you move in and you want to start compressions on those kiddos. You've tried respiratory resuscitation, you've tried oxygen, you can't get their heart rate respond. It's still, or now it's dropped below 60, and then you would start CPR on those kiddos. Even with a heartbeat, you feel it, but it's below 60, you would still start CPR on them. So kind of talking about ventilating problems, at least on our side, is in whoever's bagging, is it just a simple mask adjustment? Does it just need to reposition their airway, tilt them up, do a little jaw thrust, whatever it might be? If you're just trying to vent these little babies through their nose and their mouth isn't open, fixing these simple things might drastically increase their heart rate and get oxygen where it needs to go. And then it's thinking about where am I measuring my PSO2? Is it a right or left hand? It's low because I'm post-ductal. I'm over on my left side. So changing that stuff, making sure it's something we're not having a problem with, and it's on the patient side. So I just want to throw in this more for completeness sake. We'll use these sometimes. So especially a newborn, we can throw in a umbilical vein line up to 7 days after birth. So they'll have their clamp. We can take off their clamp from their umbilicus and throw a line. We usually use the same that we use for like an art line. We put in a little art line catheter that we'd use for arterial line. We would advance that through their umbilical vein, and kind of the difference is thinking of anatomy. They have the two arteries, umbilical arteries are on top, and then one big vein. So you're always looking for the big guy. Here, down here is this. It's kind of hard to see here, and there's 1, 2 arteries. So we would advance the catheter through that. We can do that up to 7 days if we can't get a good line. Or if we have IO excess, but we need to give them more fluid or whatever it might be, we would access that. Especially 2 or 3 days, that's quick and easy, and we can get lines really quick. Advance it till you get blood return, and then it's free to use. We'll suture it in and roll with it. We can give anything we can. It's basically a central line at that point. Let's see. So kind of still working through this algorithm, which we kind of talked about. So now their heart rate's below 60. Now you're coding the kid at that point. You're compressions, you're establishing airways, you're on ECG. Now you're starting your IVs and your EPIs and all that just to get them going, because they're not responding to oxygen, and that's number one in these little kiddos. Remember, we're talking about neonates here. So another thing to keep in mind with the little ones, the neonates, especially like right after delivery, you get called and mom's pushing and they deliver, and it's been 3 minutes, 4 minutes, and their oxygen still at 80% at 4 minutes. We have a tendency to like freak out a little bit and like, oh my gosh, they're not doing well, they're not responding. But that's completely normal. So we don't necessarily run and throw a whole bunch of oxygen on these kids that early on. Remember, it's usually 5 and 10 minutes we're getting APGAR scores, or in 10 minutes we want them to be high because they should be about 95% oxygen and doing fine. So not to keep that in the back of your head too, that they were just born, so it's going to take them a good 5-10 minutes to get up to the 80s and 90s where we want them to be without having to. And you can never hurt by throwing on some blow by, but remember, that's completely normal to be at 5 minutes and still at 80% or 75%. That's okay. So this in itself is like a 2-day course, a stable course for neonate resuscitation. It's kind of the step of PALS just for neonates. I'm not going to really talk to anybody much about it except for this, because we kind of talk about the algorithm, but it goes through each one of these. But if you just remember this mnemonic of stable for these neonate kids, and the first two are really the most important for keeping these kids stable in transport if there is any problem. You think about just sugar and temperature, checking the sugar and making sure they're warm, even to the point of our neonatologist was saying that he had a physician from an outlying facility, small ED, didn't have any resources, and he literally put the baby was 28 weeks, I think. Of course, the physician was freaking out because that's a nightmare. 28 weeks. He's an hour away from anybody that knows anything about neonates. Literally put the kid, checked the sugar, gave him some sugar, and put the kid in the blanket warmer. Literally put because he knows he could remember sugar and temperature, and ended up saving the kid's life that way just by that. They flew out, picked the kid up, and just by putting him in the blanket warmer, that type of stuff. So sugar and temperature, obviously the most important for these kiddos. The rest of the stuff doesn't necessarily apply because we'll be worried about that, and then airway, obviously. Emotional support, I always thought that was for me, like for these kids. If I had that call, but it's for the kid, like giving them as soon as you can, get them back to mom so they have support, and then mom has support too. But all right, so random questions. I got like 4 or 5, and then we'll be done. I probably went way too fast. Sorry. All right, so number one predictor for neurovascularly intact kids. What do you guys think? So if here's your little one and they went down, and there was what was the one thing that you would want? So yeah, CPR, hands on chest, absolutely. CPR. So bystander CPR is the number one predictor for neurovascularly intact kiddos. Again, that's 50%. That's pretty crappy. So 50-50 chance that your little one's going to get CPR if you're not around, which is terrifying because that's the best predictor. Say you get a call for a 6-year-old, cardiac arrest, get him intubated, you get IV or IO. So you can't get IV or IO. What medications can you give through intratracheal tube? That'd be good. Lidocaine. Okay. I can. Yes. Good. So the mnemonic for that is Lane. Lidocaine, atropine, Narcan, Naloxone, and epinephrine. In adults, there's one more. Does anybody know that one for adults? I know we're not talking about adults, but what's that? Valium's one, yeah. And then there's another V. Yeah. Versed, and then vasopressin, so you can give to. Yeah. So benzos you can give, and then vasopressors you can give if you need blood pressure up some. Good. All right. So what's the big difference for pediatric airways versus adults? Yeah, good. Anterior. Yeah, big floppy gross tongue, big epiglottis, and they're shorter, so they're higher. They're more anterior, they're shorter, which is kind of I think my next question. Yeah, anterior, superior, this is more difficult. Same way, so this is just shorter. This shorter trachea, you're not going to be driving that tube down very far. One thing you think, I got my ET2 size, but how deep do I want to go without right stemming them. And this is just a good formula too to have if you kind of keep these 3 or 4 that I've given you today. If you don't have these prediction cards, again, these prediction cards have all this on it, so it's easier, the apps. But if you had to have the 3 or 4, if I needed 3 or 4 that I was going to memorize, it'd be the ones that I gave you today or we talked about today, and just because it'd give you the most information. So how deep you're going to put that tube in that kid's throat? Remember, it's a lot shorter, much easier. It's a lot easier to right stem them. So I always do this bottom one here. So age in years divided by 2 plus 12 is how that's the one I use a lot. If we're going to have to do it just off our cuff and not be able to cheat, we get pimped on those a lot. And attending will just say, what ET tube size do you want for a 2-year-old? And we'll have nothing. We just have to do our formulas. And then, so that's always another good one to have. So I don't know if you guys used cuff, so we won't necessarily worry about that. But does anybody remember the uncuff formula for picking an ET tube based off age? So you have the patient's age. Hey, you're going to 2-year-old cardiac arrest. Anybody remember the formula? Starts with a 4. Nothing. Good, close. 4, yeah, 4 plus age divided by 4, perfect, yeah. And then, or that's uncuffed, and then what you guys would be using, and then cuffed with 3.5. Again, that's about 99% accurate. And just the point of why do we even use cuffed and uncuffed is this idea of if the patient needs higher ventilation pressure, so higher tidal volumes in these cystic fibrosis or asthmatic kids. Most common cause of cardiac arrest in kids? Respiratory, yeah. Hypoxia, yeah. That's why you're always thinking about PEA and reversible causes. Number 1 in kids could be hypoxia or respiratory. You also got to think about hypoglycemia and the other reversible stuff, but that's going to be definitely the highest on your list where you'd want to start. And so you also think about just the pathophys of that. If you go into respiratory failure, you're obviously going to decrease your respiratory drive. That's going to lead to the state of hypercapnia. So you're going to retain all your CO2 because you're not breathing it off. You're not blowing it off. CO2 in the blood is an acid. So now you become super acidotic with it. And that leads to really other bad stuff, bradycardia, hypertension, arrhythmias, arrest. And that's kind of why we get there from respiratory. Oh, so you have a decreased respiratory drive, you go into respiratory failure. Why does my heart stop? Why do I go into arrhythmias? And that's kind of the pathophys behind it. Become hypercapnic, acidotic, you become brady and hypotensive, and then you arrest. All right, that's all I got. I think Dr. Crawford comes in next. She's going to talk about postcodes. That'll be good follow-up, I guess. But awesome. Thanks for having us. I appreciate it. Awesome. Thanks, sir. Appreciate it.
Thank you very much.
Yeah, oh, absolutely. Enjoyed it. It's always fun to come out.
I can move that up. That's correct, Matt.
What's that?
Then you'll
Oh,
see that
okay, perfect.
right there.
Excellent. That's great. Let me see if I've heard it. I don't know if I was going to check to make sure Crawford found it okay. And